All right, I hope you guys enjoyed. We took a little break from the slideshow because I wanted to put in that oxyhemoglobin dissociation curve video. And it's so very important to understand that when we start having respiratory problems, that our CO2 goes up and we get that right shift in that dissociation curve. So if you haven't watched that video, go back, stop this one right now, go back, watch that other one, okay? So very important, okay, that you understand it. The reason is because when we stop breathing or have trouble breathing, we go acidic. When we have a fever, we usually end up going acidic. And that's where it shifts that curve. We don't hold on to oxygen as well, and boom, we got an even better problem. So this problem actually makes itself even worse. And it's very important to understand as we go into this next part, which is pathophysiology, okay? Because any disease process that impairs the system and results in derangement in ventilation, diffusion, perfusion, or a combination of these can cause us a problem, okay? And makes our system don't work as well, okay? And so we've got to come back and fix that. And again, it is so very important that we understand that, all right? So again, the chest wall, the diaphragm has got to be intact for good ventilation. You can also have trauma to these areas, which can cause a loss of the negative pressure in the pleural space. You can also have trauma that damages the actual tissue itself when these exchange. Breathing patterns, okay? Oh boy, we got to talk about those. Those are really key things. As a matter of fact, I might even do my own video on that one. Because again, breathing patterns are so very important. Okay, your chain stoke pattern, again, where you're slow and then you speed up. Surprised we don't have a picture of that in there. We're gonna go find a picture because I think that's important. And poof, just like that, there we go. We got a different look at here. Again, this is our normal breathing. We're breathing fast. We're breathing slow. We're not breathing. But again, the chain stoke patterns here. They start small, get bigger, get really big, get really big, get really big, small, and then it goes back to nothing at all. Usually your disease process is involved is usually it's kind of like a dying respiration, if you will. Biot's respiration, again, really deep respirations followed by periods of apnea, usually involved in trauma. Same way with apneuristic. These guys are usually all involved with trauma. Agonal breathing, of course, it's a gasping for air. Air trapping is when you get too much air in, you force too much air in and it can't actually get out. The best way to stop the air trapping, by the way, is to simply disconnect the bag and let the air drain out. Okay, it sounds kind of weird, but yeah, it is. You can have shallow. Again, hypernia is basically tachypnea, except it's big and deep. The Kussmaul's is a forced, where the body's actually breathing fast in order to maintain a balance between a metabolic acidosis by putting you into respiratory alkalosis, okay? A little bit that happens also with aponeuristic as well. Again, this is usually due to a trauma. This is usually due to a metabolic condition, okay? So it's really important to understand your sighing there. And boom, just like that, we're back to the regular slides. How do you like that? Again, changes in diffusion. Any change in the concentration of oxygen, of course, if you take away oxygen, it's not going to diffuse. Remember, diffusion happens because of areas of high concentration to the areas of low concentration without the use of energy, okay? Breathing does not require an energy use other than to create the negative pressure, okay? Everything else is done by a diffusion state. And if you've got something that thickens the membranes, thickens the fluid, makes the fluid layer deeper, inflammation of that cell wall around the alveoli, any of those things can throw off the diffusion process, okay? And you got to know where you're dealing with that, because again, the simple statement of I'll just bag them and give them more oxygen sometimes doesn't work, gang. So we got to be able to understand that and figure out, oh yeah, I've got too much water in the lungs, which is causing the problem. So maybe if we find a way to get the water out of the lungs, I don't know, increase the heart rate, allow the kidneys to pee it off. These are ways that we can fix respiratory problems in certain cases. By the way, the flip of that is also true. If I've got somebody with a pneumonia and they're dry and I decide to dry them out even more, I can cause them to get sicker. hint, hint for your COPD versus CHF essay. Really, you might want to pay attention to that little factoid, okay? Disease states, again, are that alter the pulmonary capillary endothelial lining. Sepsis, COVID, both of those interfere with those, all right? So, again, disease process can play that terrible problem with that. Pulmonary shunting is an area of lung tissue that is ventilated, but no perfusion occurs, usually due to a pulmonary embolism. So think about that. You're losing all of that alveolar space because the blood's not flowing in between two of them. Okay? By the way, if you reduce circulating hemoglobin, let them bleed out, again, this is going to affect the perfusion of the patient. We constantly tell you guys, we'll just give them normal saline, we'll keep their blood pressure up. Well, there's got to be a certain amount of red blood cells in order for that little theory to work. And if you don't do that, if you don't hold on to those little red blood cells, eventually you will run out. And once you run out, normal saline does not carry oxygen, okay? Boy, if we could ever invent the fluid that did that, we would be extremely rich, okay? So scene size up, okay? Remember, is it safe to get in there, all right? Make sure, look around, certain gases and toxins, if you will, the canary, is there a bunch of dust particles in the area? Are those dust particles glowing a certain color? Maybe you might not want to go in there, okay? Remember that just because it's clear might not mean that it's a oxygen-filled area, okay? Grain silos and closed storage containers, guys, anything that's got an active fire eats up the oxygen in there, okay? Grain silos, it's fermentation processes, burn up the oxygen, okay? So you walk in, hey, thunk, you're down, okay? Because there's not enough oxygen in that air to support life, all right? So make sure, when in doubt, again, you should have your SCBA on. If you don't have you don't know how to use an SCBA, learn how to. And if you don't know how to use it just yet, again, you shouldn't be going into that area. Simple, long, and short. Again, if you need a hazmat team, you call them in. Running in there, grabbing the patient, and doing a rescue could be dangerous to you, okay? Again, situation kind of dictates the tactics. But again, if there's any question that you might get harmed by doing a snatch and grab, you shouldn't be going in there. Period. Exclamation point. Using your eyes, ears, nose can lead to important clues to the patient, to assessing your patient. More importantly, to assess for hazards that are in the area. When you walk in, you want to see it. You might actually walk in on them in a bad position, tripoding positions. In severe cases, again, patients with severe respiratory distress might be pale, cool, diaphoretic. And cyanosis, by the way, gang, I've always said, pink is good. Anything but pink is bad. Cyanosis, turning purple or sure blue, is really bad, and it doesn't need to wait till the truck to start fixing it, okay? We need to start fixing that now. So again, this is a tripoding position. What are they actually doing here? They're actually lifting up their shoulders to create more space in the thoracic cavity. By the way, newsflash, this requires more energy. Eventually, they're going to get more acidic, they're going to give out, and they're going to get worse very quickly, all right? Again, do your general assessment. Again, they may be restless and agitated. They may be even combative with you, okay? They could be definitely confused, especially if they have either low oxygen or high carbon dioxide, okay? Guys, that is a imminent respiratory failure situation. We got to start something right then, right there. It doesn't wait till the truck, all right? You've got to start ventilating that patient, getting in oxygen, okay? Then let's worry about getting him to the truck. Again, I'm not saying it's not important. I'm saying that we got to start the airway and ventilation process, or you're going to be doing a whole lot more work that you don't want to do, all right? General impression, again, make sure, ask them, start asking them simple questions. If they're only saying one or two words, okay, we're good. Keep the questions to yes and no. If they're rambling or incoherent, they got fear, anxiety, and they're going to be telling you, I can't breathe. Again, you've got a patient in severe distress, and at that point, you need to act appropriately. All right. Your nasal flaring, look for the use of accessory muscles. Pursed lips, they're actually trying to create their own PEEP. They're trying to open up those air sacs, okay? Obviously, if they're turning blue or they're actually grabbing at their throat or trying to make their lungs bigger, again, if they're doing any of these things, you need to be aware of it. And again, these are compromises to their airway and their breathing, and you need to fix them absolutely right there. Make sure, by the way, that we don't have anything in the upper airway, any type of obstruction. And again, the brain can survive only a few minutes without oxygen. So again, we got to make sure that that air is going in and out, okay? If it's not going in and out, again, if you got an airway that is blocked, no matter how well you ventilate or try to ventilate the patient, the air is not going in, it's not going to work. You're going to have to find a different way. If the patient's, if you got a patient that's apneic, it doesn't matter. Remember, guys, that my saying has always been air goes in and out, okay? And if it doesn't go in and out, we need to make sure that it does go in and out, okay? So if you've got an airway obstruction, again, don't waste time. You need to act immediately. How do we do that? A basic life support maneuver, again, abdominal thrust. Anything that you need to do to open it up. If you need to, direct laryngoscopy. Remember, how long does it take you to find your McGill forceps and your laryngoscope, okay? We're talking 20, 30 seconds. That's an eternity, considering your response time was probably somewhere between the 5 to 10 minute mark, all right? If the airway is compromised, again, basic airway techniques. Once you've secured the patient's airway, ensure that the patient has adequate ventilations, okay? The assessment should be brief and directed. Again, air needs to be going in and out, okay? And again, 99 times out of 100, this is what happens with our patients, okay? Look for a couple things. They can't say things. They don't have any breath sounds. You can hear the air in their upper airway trying to get through. Audible stridors. They have central cyanosis. They're 130 beats a minute with tachycardia. And again, when a patient gets in trouble, their heart rate goes up, their respiratory rate goes up, okay? So again, double check all of these things. If you got pallor, diaphoresis, they're using their other muscles to breathe, that the sternocleidomastoid, all of these neck muscles, in order they start collapsing in and out as they breathe. They're using the muscles in their chest to augment, to make things bigger so they can suck more air in. These are signs of respiratory distress and compromise, and we need to act. All right, we're going to save this next slide to the next video, and I will see you then.